So today's topic is acute laryngitis. So laryngitis is the inflammation of larynx. So it may be due to infection or maybe due to some other noxious stimulus, uh, including loud speech or shouting, etc. Okay, or any chemical stimulant like acids or hyperacidity, etc. or extra hot food or drink. These can cause damage to the larynx and can lead to the inflammation of larynx, which is known as acute laryngitis. And depending upon the course of the disease, it is termed as acute or chronic. Okay. Acute inflammation of larynx leading to the edema of laryngeal mucosa and underlying structures, mainly in the glottic area. Glottic means the region which is related to the tongue. Okay, so in laryngitis or in acute laryngitis, there is obvious inflammation of the larynx and it leads to edema of the laryngeal mucosa and underlying structure. So there is swelling. There is swelling of the laryngeal mucosa, that means the inner mucous membrane of the larynx or mucous layer of the larynx, and the associated area, especially the glottic area or the tongue related area, gets swollen up. Okay, so there is edema. The etiology or the causative factors are infectious. Among the infectious laryngitis, the causative organisms are virus and bacteria, and among the non-infectious agents or non-infectious causative factors of acute laryngitis, there are inhaled fumes, allergy, polluted atmosphere, etc. Vocal abuse, that means shouting or speaking for a very long period of time. Like this acute laryngitis is very common among the singers and among the teachers who keep on speaking for a very long time and for a very long duration and long period of time. That means in a particular day they speak for a long time, and in their whole lifetime also they speak for a long time. So the vocal abuse or the over usage of the vocal box is the reason. Next is iatrogenic trauma, that means drug related trauma. That means it can happen as a side effect of any chemical drug. Okay. Next is predisposing factors. These are smoking, psychological strain, physical stress. So these are the factors which can predispose or which can help in the precipitation of this disease. Okay, so if these factors are present, then the disease is more likely to affect that person. Okay, now we will see the clinical features or the clinical manifestations of this acute laryngitis. Number one, this is hoarseness or change of the texture of the voice. That means when the patient is affected by acute laryngitis, his or her voice quality will change. That means his or her voice will be rough and hoarse and coarse in nature. Okay? The voice texture will change. It will not remain the same anymore. Pain and discomfort in the throat. Obviously, larynx falls in the throat area or throat region. So whenever there is inflammation and edema of the laryngeal mucosa and underlying structure, there would be pain and discomfort in the throat. What happens is that when there is edema in the laryngeal mucosa and underlying structure, these get swollen up. The inner lumen, due to the swelling of these structures, the inner lumen of the larynx get narrowed. Okay, so that is why there is pain in swallowing as well as pain as well as the resting pain is there. That means when the patient is not doing anything or the patient is at rest, not speaking at all, so then also there will be pain because of this swelling the lumen will be narrowed and there would be pain in the throat or larynx region. Next is dysphagia. Dysphagia means difficulty in swallowing. Since the lumen will be narrowed down, so the food bolus will be difficult to pass through the larynx. Okay. Next is dry, irritating, paroxysmal cough. Since there is inflammation in the laryngeal area, maybe due to infection or non-infectious reason, so there would be irritation in the laryngeal area, and that would lead to the production of cough. Okay. Next is fever and malaise. So fever itself is a cardinal sign of the cardinal symptom of the inflammation. Whenever there is inflammation, there would be rise of body temperature. Okay. So in mild inflammation, the rise is very low, and in severe inflammation, the rise of temperature would be high, and it would be called fever. Okay. So the temperature would be greater than 98 degree Fahrenheit. Okay. So in that case, it would be called as fever. Okay. Or 37, it would be more than 37 degree centigrade, or it would be called as fever. Malaise means weakness. Okay. Weakness and accompanied with dizziness, etc. So there would be discomfort. The vague discomfort and weakness is called malaise. Okay. Signs and symptoms of acute URTI, that means acute upper respiratory tract infection. So okay, so in case of acute laryngitis, their symptoms and signs would be mimicking those of the upper respiratory tract infection. Okay. Next is dry sticky secretion from the laryngeal area. Why? Because the mucosal layer is affected. The mucosal layer is affected and it has swollen up. So that is why there would be sticky secretion or discharge. Okay. Next is congested and swollen vocal cord. So the swelling and edema of this laryngeal area would affect the vocal cord or vocal apparatus or vocal box as well. So this vocal box will also be swollen and congested. Okay. Diffuse congestion of the laryngeal mucosa. Obviously, the laryngeal mucosa would be swollen up and congested. Okay. So, and these are the general features of the acute laryngitis. And in laryngoscopy, there would be in acute laryngitis. If we perform a laryngoscopy, we will find hyperemia and edema of the vocal cord. So this is these two, that means hyperemia and edema of the vocal cord, are the laryngoscopic findings of acute laryngitis. Okay. See here, these portions are red. That means these are congested and inflamed. Okay. So this is the laryngeal area. Okay, this is the epiglottis. Okay, this is the epiglottis. See, even this portion, since in laryngitis the glottic area is also involved and edematous. See, here also the glottic area or the epiglottic area has been swollen up. So this slit or this lumen has been narrowed down due to the swelling of the adjacent structure. Okay. Here you can see that in laryngitis, the whole glottic area, including the tonsils, have been inflamed. Okay. So here you can actually find some spots of pus. So in this case, this has been suppurative. This has been suppurative in nature, and there is pus inside this. So this is a suppurative inflammation of the laryngeal and associated area. So this is the endoscopic finding or laryngoscopic finding. Generally, it is called endoscopic finding, and on the basis of the site of the endoscopy, these are known as some different name like laryngoscopy, colonoscopy, proctoscopy, etc. But in general, this is endoscopy. Okay, so here also you can see that the mucosal layer here, this white portion, these are the mucosal layer. So this layer has been inflamed and congested, and there is discharge. Okay, so there is swelling and there is discharge. Okay, so this is a finding of acute laryngitis. Here also you can see highly congested laryngeal portion, which is highly congested and edematous. So this is another feature of acute laryngitis. Okay, so treatment. So whenever there is infection, we treat it with antibiotic. So in case of infectious acute laryngitis, antibiotic is the mainstay of treatment. Analgesic is used to relieve the pain of the patient, and steroid is used to reduce the inflammation and the edema. Voice rest would lead to the quicker recovery. Okay, so if the patient is at voice rest, his or her recovery would be rapidified. Okay, so if the patient keep on speaking, or if the patient has to keep on talking or singing, etc., so her condition will be worsened. Okay, next is non-spicy food. This is also very important, that the patient has bland diet. Okay, the patient is put on bland diet, but extra spicy food, especially chili and hot, also hot food, etc., hot drinks, etc., this would lead to the damage of the laryngeal mucosa and the inner layer. Okay, so it is important for the patient to stay on bland diet for the time being. Next is chronic laryngitis. When the condition is persisting for more than 3 weeks, then we call it chronic laryngitis. So this can be a sequel of acute laryngitis, or it can be a result of some other infection which can lead to the chronic inflammation of the larynx. Chronic inflammation of the laryngeal mucosa is known as the chronic laryngitis. There are basically 3 types of chronic laryngitis. Number 1 is chronic simple laryngitis, chronic hypertrophic laryngitis, and atrophic laryngitis. Okay, so 1 is simple chronic laryngitis. Number 2 is chronic hypertrophic laryngitis. That means there would be hypertrophy. Hypertrophy would be associated. Okay, hypertrophy means increase in size, and hyperplasia means increase in number of the cells. Next is atrophic laryngitis. Okay, so we will see the clinical features of the chronic laryngitis in general. That means these clinical features are present in all these 3 types of chronic laryngitis. Okay, so number 1 is hoarseness of voice. That means rough or coarse voice, where texture of the voice would be changed and the voice quality will not remain the same anymore. Okay, next is sore throat. It is quite obvious that whenever there is long-standing inflammation and edema of the larynx and laryngeal mucosa, there would be obvious soreness in the throat region. Next is weak or absent voice. The voice would be sunken or completely choked. That means the patient will not be able to utter a single word. So why this happens? Because this long-standing chronic inflammation leads to the damage of the vocal apparatus as well. So the sound is not produced the way it should be. Okay. Next is sensation of lump in the throat. Since there is huge edema and congestion and hyperemia in the laryngeal mucosa, the inner lumen, so due to the edema of the associated structure, the inner lumen of the larynx is narrowed down. Okay, and since there is edema, there is a sensation of fullness, there is a sensation of mass. Okay, so that is why the patient might complain that I'm having some mass or some tumor in my throat. I'm feeling like that. Okay, so this happens due to the swelling and the swelling of the laryngeal mucosa, which actually leads to the narrowing of the laryngeal lumen. Next is constant need and urge to clear the throat. Since there is mucosal involvement, so there is, as we have already seen, that there is mucosal discharge. There is mucosal discharge, a sticky discharge in the lumen. Okay, so in acute laryngitis we have seen this. In chronic laryngitis this becomes even more severe, and due to this secretion, due to this over secretion of the mucosa or mucus, the patient feels uncomfortable, and he or she tries to clear the throat, clear the secretion, so that he or she can speak properly or can even breathe properly. Okay. Next is dry cough. Dry cough was there in the acute laryngitis as well. So here also, especially due to the secretion, due to the over secretion of the mucosa, there would be dry cough, dry and non-productive cough. Okay. Next is fever. This is quite obvious that whenever there is a long-standing inflammation, it would be accompanied by fever. See here, like in acute laryngitis, the hyperemia was less, congestion was less. Since this is a long-standing condition, everything has become more severe. See, the hyperemia has been more, the congestion has been more, even the swelling has been more. See, this portion and this portion, these two have come so closer, making the lumen so small. Okay, this is actually what happens. If these portions are swollen up, the lumen is narrowed. Okay, if these portions are swollen up, the lumen is narrowed. This is an endoscopic view. This is an endoscopic view where we can see the mucosal congestion. Okay, the mucosal congestion and mucosal edema. Also, we can see traces of mucosal secretion here. Okay, so these structures have damaged, and we will see later. This is a nodule. There is a nodule formation. We will see and learn the voice nodule separately. Okay, later. This is voice nodule. This is a form of chronic laryngitis. Okay, so whenever there is long-standing inflammation of the larynx, it leads to edema. As we have already seen, that leads to severe edema. So when edema is localized, the a nodule or a papule type of structure is formed. Okay, so this is known as vocal nodule. Okay, so this might be bilateral. This might be bilateral, and the classic location, that means most common and most characteristic location of the vocal nodule, is at the junction of the anterior and middle third of the vocal cord. So here the nodule is there at the junction of the anterior and middle third, anterior and middle third, one third, anterior and middle third of the vocal fold, and this is present symmetrically. That means since this is bilateral, this would be the two vocal nodule would be present symmetrically, and it would be white little hard nodule. The texture of the nodule would be hard, and it would be tiny nodule, and it would be whitish in color, and this is extremely irritating and extremely painful sometimes. This is extremely irritating, and the patient's voice gets affected to a large extent. Okay, and the patient feels constant need to clear up his or her voice. Okay, this This leads to a foreign body sensation as well. The patient feels that something is stuck in my throat. Okay. Next is treatment. The treatment is antibiotic steam inhalation. So if the patient takes vapor, or the patient sucks in the vapor or steam, then he or she is relieved. So the edema of the larynx and associated structure gets compressed, gets uh, gets hot compressed. Okay, like what we do in the in some abscess, to drain some abscess, etc. We hot compress. We dip a cotton pad in the lukewarm water and then we press. So same thing happens when the patient inhales steam or vapor. So his or her throat is relieved. The pain is relieved to a large extent. Voice rest. Whispering can cause more pain than speaking. So this is another important feature, that when you whisper, the pain would be even severe than while talking. So while whispering, the voice box is even more affected. Okay, so the voice box is even more affected while whispering. Okay, it leads to the development of more pressure on the voice box while whispering. Okay, so voice rest is a must in case of chronic laryngitis. Next is surgery. If the condition does not respond positively to all these above mentioned ways of or modalities of treatment, then we will have to go for surgery, either for removal of the vocal nodules or for removal of the inflamed and severely damaged portions of the larynx. Can be helpful to relieve the patient from his or her severe pain. Next is carcinoma of the larynx. This is a very important topic and we should focus on some important points which are important with respect to the MCQs. Okay. Number one is etiology. So among the causative factors, there are cigarette smoking, which comes at the top of all the causative factors. So cigarette smoking, alcoholic drink, smoking plus drinking increases the risk to 50% more. So a patient or a person who smokes as well as drinks alcoholic beverage, he or she is 50% more, he or she is at 50% more risk than the normal individual who does not smoke and does not drink. So this is an alarming sign, and why patients should be advised to stop smoking and drinking alcoholic beverage. Next is air pollution. Next is virus and precancerous lesions like leukoplakia and papilloma. Papilloma, we know that there would be papule formation, and leukoplakia means, leuko means white and plakia means patches. Okay, so white patches in the on the tongue. So leukoplakia is a precancerous lesion, and whenever there is leukoplakia, the patient should be checked or examined to rule out cancer. Okay, this is a very common precancerous lesion. That means there would be white patches on the tongue. Okay. Next is sex hormone. That means the androgens. Sex androgens are responsible. Overusage of sex androgens can lead to the causation of laryngeal carcinoma or carcinoma larynx. Okay. Next is pathological variation. So squamous cell carcinoma, this is the most common and constitute almost 98% of all the carcinoma larynx. Other variants are adenocarcinoma and undifferentiated carcinoma. Okay. Classification are glottic, supraglottic, subglottic. Okay, so this classification is based on the site of carcinoma. Okay, glottic means on the tongue. So this constitute around 60% of all the laryngeal carcinoma, and this is very well differentiated, and this metastasize later. Okay, the course of metastasis comes later. Okay, so the prognosis is better. Next is supraglottic area. So that means this is over or above the glottic area. Okay, so this constitutes around 30% of all the larynx or carcinoma, larynx or laryngeal carcinoma. This is fully differentiated and this metastasizes earlier. Okay, so for this the prognosis is worse. Okay, so this in this variant, what happens is that the metastasis starts earlier. So when there is metastasis, there would be involvement of other distant organs. So that would lead to the collapse of the whole system eventually. Okay, so that is why the prognosis of this variant is worse. Next is subglottic carcinoma. So this subglottic area means the area which is below or beneath the glottic area. This forms or this constitutes around 6% of all the carcinoma larynx, and in this also there is poor differentiation and early metastasis. Poor differentiation and early metastasis. Here also the prognosis is bad. So only for glottic variant there is well differentiated mass, and there is late metastasis which leads to the better prognosis. Okay, so in general the 60% of the larynx carcinoma larynx is glottic type, and have better prognosis. Both for supraglottic and subglottic type of larynx carcinoma, the prognosis is worse, and there is poor differentiation of the presenting mass, cancerous mass. The route of metastasis. The route of metastasis, number 1 is direct spread, number 2 is lymphatic spread, and number 3 is hematogenous metastasis. Okay, so hematogenous means it spreads through blood vessels, and lymphatic metastasis means it spreads through lymph nodes. Okay, so among direct spread, there's supraglottic cancer. It spreads to the epiglottic area, pre-epiglottic space, vallecula, and the base of the tongue. Next is piriform sinus, lateral wall of hypopharynx, and paraglottic space and ventricles. So in case of supraglottic cancer, the metastasis through direct spread involves these particular area. That means epiglottic area, pre-epiglottic space, vallecula, and base of the tongue, piriform sinus, lateral wall of hypopharynx, paraglottic space, and ventricle. In case of glottic cancer, anteriorly through the direct spread, the cancer spreads to the contralateral vocal cord anteriorly. Contralateral means the other side. Okay, ipsilateral means the same side. Okay, so the contralateral vocal cord is affected in case of glottic cancer. Okay. In case of glottic cancer through direct spread, direct metastasis. Posteriorly, the arytenoid cartilage is affected, and superiorly, the supraglottic area is metastasized. Okay. Next is inferiorly, paraglottic space and subglottic area are involved. Next is subglottic cancer. In case of subglottic cancer, the cancer spreads through direct spread in the glottic area, superiorly in the glottic area, anteriorly and laterally, to the strap muscles and thyroid gland, and posteriorly it involves or it spreads to the esophagus. So the other routes are lymphatic metastasis and hematogenous metastasis, where it spreads to lymph node and blood vessels respectively. Next is the signs and symptoms of supraglottic cancer. These might be initially asymptomatic. So this is very dangerous and leads to poor prognosis, since in the earlier stages it remains asymptomatic. So the patient cannot feel that there is a huge pathology inside his or her body. So that is why medical attention is not sought, and the patient presents with the problem when it worsens to a large extent. Okay. Next is foreign body sensation. As I already mentioned that whenever there is mass or nodule in the laryngeal area, there would be foreign body sensation. The patient will feel like there is something stuck in my throat. Okay, so this is known as foreign body sensation, which is obviously accompanied by irritation. Okay, next is pain on swallowing. Since there would be edema and there would be mass in the larynx, so this would again narrow down the lumen of the larynx, making swallowing painful. Okay, next is throat burns. The irritation of throat would be so severe that it would feel like burning sensation. Okay. Next is cervical lymph node enlargement. Since there is malignancy, that the sentinel lymph node would be affected. Okay, the sentinel and the associated lymph node would be affected, and that those would be engorged and enlarged. Okay. Next is glottic cancer. In case of glottic cancer, the voice texture would be changed, which is the earliest symptom, and the voice would be hoarse and coarse and rough. The respiratory obstruction in the later stage would show up. Next is in case of subglottic cancer, no definite symptom in early stages. That means in earlier stages it could be asymptomatic, and dyspnea and lymph node metastasis would be there in the late stage. So whenever the malignancy progresses to a more severe form, then there would be dyspnea or discomfort while breathing. So there would be pain in the laryngeal area, which would cause the painful breathing. Next is finding on physical examinations. So there would be mass on laryngoscopic examination, fixation of the vocal cord, and mass in neck. So there is mass, and there is new vascularization or new blood vessel formation. These new blood vessels provide nutrition to this mass and encourages the cancer to get bigger or get more severe. Okay, so here also there is the lining, the inner lining is damaged, and we can see that there is severe damage of the inner lining of the larynx, and there is kind of mass formation here. There is kind of mass formation here. Here, see, here also there is mass formation and severe damage. This is an endoscopic view which tells us about the severe damage of the laryngeal area. Here also we can see engorged mucosa and presenting mass. Here we can see bleeding. Here we can see severe hyperemia and bleeding due to the presenting cancer. Here we can see these mass and swollen appearance of the mucosa, of the laryngeal mucosa. Next is treatment. What are the treatment modalities? These are radiation, transoral, laser resection, laryngeal surgery, combined therapy. Combined therapy means radiation and chemotherapy, partial laryngectomy, rehabilitation of the speech, and neck dissection. So partial laryngectomy is done when there is indication for partial laryngotomy and there is rehabilitation of speech possible, and neck resection if the actually neck resection if the presenting mass is very large. Next is laryngeal obstruction. So that means blockage or obstruction in the larynx area. Etiology. So these what are the factors that can cause obstruction or blockage in the laryngeal area? These are tumors, infections, foreign body, trauma, allergy, or laryngeal paralysis. The paralysis of the smooth muscle of the laryngeal area. So signs and symptoms. These are inspiratory dyspnea, that means difficulty while inspiration. Inspiratory stridor. Stridor means extreme struggle. Depression and depression of suprasternal fossa, supraclavicular space and intercostal space. So there would be, this is known as the 3 depression signs. So 3 depression sign would be positive in case of this laryngeal obstruction. Okay. Next is depression of the epigastrium. Epigastrium means the upper half of the in the abdominal regions, as we have studied in the surgery. In the abdominal regions, the abdomen is divided into 9 sections. Okay, so in the middle section, the upper half is known as epigastrium, gastrium, and hypogastrium. These are the 3 sections of the gastrium, or of the middle section of the abdomen. So okay, so depression of the epigastrium would be there. Hoarseness of voice or coarse or rough texture of voice would be there due to the obstruction or blockage in the laryngeal area. Next is cyanosis. Cyanosis is a sign where there is bluish discoloration of the body parts, especially of the peripheral parts of the body. Okay, so these are the pictures of laryngeal obstruction. See, this is a mass which is called laryngeal obstruction. This is also a mass. This is probably a foreign body, and this is actually cancerous mass or malignant mass. Classification. So basically these obstruction are grouped or classified into 4 stages. Number 1 primary, number 2 secondary, number 3 tertiary, and number 4 is quaternary. So based on the signs and symptoms and their severity, they are classified into these 4 groups. So number 1 is primary obstruction or symptoms of primary obstruction. These are no symptoms at rest. When the patient is at rest, there would be no discomfort or no symptom. Inspiratory dyspnea, stridor during crying or exertion. Whenever the patient faces any exertional activity or the patient cries, then there would be inspiratory dyspnea and stridor. Next is secondary stage of laryngeal obstruction. So here there would be slight inspiratory dyspnea during quiet respiration and exaggeration on exertion. Sleep and appetite almost normal, no hypoxia would be there. That means the inspiration would be sufficiently normal. Next is in secondary stage of laryngeal obstruction, what happens is that there is slight inspiratory dyspnea during the quiet respiration or at rest. So whenever the patient is exaggerated or faces any exertion, then there would be slight inspiratory dyspnea, and sleep appetite would be normal or almost normal, and no hypoxia would be there. Since the breathing is not affected that much, so the oxygen content of the blood would remain the same. So there would be no hypoxia. Next is tertiary. Here There is marked inspiratory dyspnea, loud strident, 3D sign, that means 3 depression sign, cyanosis, restlessness, air hunger, rapid pulse, increased blood pressure, and food refusal. Since in the tertiary stage of laryngeal obstruction, there is marked inspiratory dyspnea at rest. That means even without performing any exertional activity, the patient would be struggling. Okay, there would be discomfort during inspiration, which is known as inspiratory dyspnea. There would be loud stridor, or the patient would be struggling loudly, and the 3 depression sign would again be positive. There would be cyanosis. That means whenever there is the respiration is not proper or is not the way it should be, there would be cyanosis, because there would be buildup of carbon dioxide in the body, which will lead to the bluish discoloration of the peripheral parts of the body. There would be restlessness, because the breathing is not proper, the breathing is not performed the way a normal person breathes, so there would be restlessness. Air hunger would be there. Air hunger is why? Because when the respiration is not sufficient, the body will try to engulf more and more air. Okay, he or she will be feeling that I'm getting less air and I need to get more. So this is known as air hunger, hunger for air. Next is rapid pulse. Pulse will be rapid and the blood pressure would be increased. The patient will refuse the food. Why? Because the patient is feeling severe pain. Severe pain is felt by the patient, which leads to the food refusal. Okay. Next is quaternary. Here, severe dyspnea, restlessness, sweating, cyanosis at rest can be there. There can be rapid pulse, decreased irregular and weak blood pressure, circulatory collapse, asphyxia, or cardiac failure. So these are the range, or these are the spectrum of some signs and symptoms which are seen in case of quaternary laryngeal obstruction, okay, which can even be fatal due to cardiac failure. Okay, next is treatment. The treatment modalities of different types of laryngeal obstruction are etiological, or that means the removal of the causative organism or elimination of the causative organism by antibiotic or corticosteroid. Next is secondary. For secondary obstruction, we also administer etiological therapy. That means elimination or removal of the causative organism or the causative stimulus. Tracheostomy for tumor, trauma, bilateral vocal cord paralysis, etc. For tertiary laryngeal obstruction, medical treatment is done under observation and tracheostomy may be performed. For quaternary laryngeal obstruction, cricothyroid membrane puncture, cricothyroidectomy, and tracheostomy are done. Purpose of tracheostomy, these are, that means increased clearance, breathing adjuvant, establishing better airway, reducing anatomical dead space, decrease respiratory resistance, and ventilator suction. So these are the purpose why we do a tracheostomy for. See, this is the picture of tracheostomy. Okay, there is a hole made here and a pipe is later on connected to this hole, okay, like this. Next is complications of tracheostomy. Severe bleeding, airway becomes trapped in the surrounding tissues, pneumothorax, mediastinal emphysema, etc. Okay, so these are the complications of tracheostomy. Now we would see the diseases of trachea and esophagus. Trachea lies in between the neck and the thoracic cavity. That means it is in the junction of the neck portion and the thoracic cavity. This is This is composed of 16 to 20 tracheal rings. 7 to 8 rings are there in neck ridge. Carina is the end of trachea where the tracheal bifurcation takes place, and the sternal angle is at T5 at resting position or T4 during inspiration and T6 during expiration. This is an important landmark of the landmark for performing bronchoscopy. Bronchial tree. This is the angle between trachea and bronchus is 45 degree in left and 25 degree in the right side. That is why, since the right side the inclination is less and it is more vertical at right side, and it is also more wider in right side. That is why foreign body is more prone to be lodged into the right bronchus. See here the with the main central axis, the left bronchus makes an angle of around 45 degree, and the right bronchus forms an angle around 25 degrees. So this one is more vertical and a bit more wider. So the foreign body is more susceptible to get lodged in the right bronchus. So this is the bronchial tree. This is the carina where the bronchial tree or where the trachea bifurcates. Okay, so this is one bronchial. So this is one cartilage and this is one tracheal cartilage. Okay, which can open posteriorly. Next is esophagus. This is a muscular organ and pipe-like in shape. Outer to inner, there are 3 layers. From outer to inner, there are 3 layers like muscle layer, submucosa, mucosa, muscle, submucosa, and mucosa. And for there are 3 physiological constriction in the esophagus. Physiological constriction means 3 narrowed part. Okay, one is here, one is here, and one is here. So 3 physiological constrictions are there. Their site is very important. Like the distance from the incisor tooth or from the incisor tooth is measured and it is documented. Okay, so the first constriction is at 16 centimeter from the first incisor. The second one is at 23 centimeter from the incisor, and the third one is at 38 to 40 centimeter from the upper incisors. Okay, so this site of physiological constriction is very important. The next is foreign body in trachea and bronchus. So 90% happens, or 90% prevalence is there in case of children less than 5 years, and 80% prevalence is there in case of children less than 3 years. Classification of foreign body. So based on the types and the characteristics and the origin, the foreign bodies are classified into different classes or different types. Like plant, for plant source there is peanut or there are seeds. From animal source there are fish bone or piece of bone. From synthetic, among the synthetic material there can be dental prosthesis. Okay, and for mineral this can be iron, for others it can be nail. See, these informations we just need to remember. Okay, we just need to remember these informations. Factors associated with common presentation: type, size, site of foreign body, and presence of infection. Presentation can be divided into 4 stages. Number 1 is stage 1, which is inhaled period. Here there would be cough and dyspnea, that means discomfort in breathing. The second stage is quiet period. There is no symptoms. So initially after the lodging of the foreign body into the larynx, there would be cough and dyspnea, and after some time it would be quiet. The patient would fall quiet. He or she will not be showing up any signs or symptoms. Stage 3 is the infection period. Cough, dyspnea and fever would be appearing or reappearing. Next is complication period or stage 4. Here atelectasis, emphysema and lung infection occurs, which is very worse, and it can even be fatal or can cause asphyxia in the patient. Locating the foreign body through X-ray or CT scan needs to be done, and most location of foreign body in esophagus is the most common location of foreign body in the esophagus is in its first constriction. That means around 16 centimeter away from the upper incisors. Okay, so this one is 16, this one is 23, and this one is 37, and the last one is 36. So in some books it is given as there are 4 constriction like this, and in some book there are given that there are 3 constriction in the esophagus. So you remember this, and the 3 constrictions are more commonly used. Next is complication. Among the complication of foreign body lodgement of foreign body in the larynx can cause some complications like asphyxia, perforation, infection, emphysema, large artery disruption, tracheoesophageal fistula, etc. The removal of foreign body is done through a bronchoscope or an esophagoscope or a gastroscope or surgical opening Next is the treatment. That means the removal is mainly, the mainstay of removal is basically endoscopy. Okay, so this foreign body is extracted through an endoscope. Okay, by inserting an endoscope, we can view the inner. We can have an inner view of the larynx or the esophagus on the monitor, and by locating that we can extract or we can remove the foreign body from the larynx or from the esophagus. Treatment of the associated condition with antibiotic, analgesic and anti-inflammatory drug, that means steroids. Okay, so even after the removal of the foreign body, there might be some associated damage in the related area. Okay, so that damage has to be controlled or has to be healed by some medication. So these are antibiotic, analgesic and anti-inflammatory drugs. See here, there are some metal balls lodged in the esophagus, and in X-ray it shows up like this. Here the patient has swallowed a coin-like radio opaque element, which is shown up in the X-ray. Here also there is one coin or disc-shaped thing, and there is one safety pin in the larynx, in the larynx or in the esophageal area. In all these cases, there are some foreign bodies in the laryngeal area or the esophageal area. Okay, so here by inserting an endoscope from the mouth of the patient, the inner view can be viewed on the monitor, and the foreign body can be extracted by the endoscope itself. Okay, by a probe itself. So this is how the foreign body is extracted or removed from the larynx or esophagus.